So I want to transition from here to our first sort of content segment, which I've just called useful mental health concepts. So one thing I've realized in working with teens is there's some really good stuff that I learned in my mental health training that has helped me maybe take a little bit more of a spacious stance towards the people, both clients and colleagues, that are challenging for me to work with. And so I wanted to share some of those frameworks with you all. And can I just get a show of hands, who are mental health professionals of some kind in this group? Okay, cool. So this will not be familiar to you, and that, or it may, but it not because you've studied it. That's fine. So I'm going to wait and do this later. So, you know, when I've started having these conversations with a lot of the community health teams that I work with, their comment is, yeah, but we're not therapists. Do we really need to know this stuff? And my response to that is kind of the more different ways of thinking you have in terms of understanding what's going on for humans and also what's going on for yourself, the more effective you can be in your work. So I think what I want to offer is just an invitation in this and some of these concepts to see what resonates with you and sort of try it on. And you know, if it doesn't make sense, you don't have to buy it. Also, just to say, you know, a lot of the concepts that come out of sort of the Western model of mental health have cultural limitations and contextual limitations, and so there's stuff that I'm like, well, that just doesn't really work. And in this, you know, in this context or with these particular individuals or families I'm working with. So, you know, take it as a resource. That's what I want to say. So we're going to go over kind of 7 key concepts for mental health that I think are helpful in making sense of why people do what they do and why we feel the way we feel about it when we do. So ambivalence, defenses, projection, unfinished business, transference, and countertransference. So ambivalence, if you've done much motivational interviewing, this may be the most familiar of these terms. Does anybody know what, I'm going to go back so you're not reading from my slide. Go backwards. Mike, does this thingy work? Make it work. Okay. Oh, that was the other direction. Yeah, okay. And so anybody know what ambivalence is?
Indecisiveness?
It can manifest as not being able to make a decision. Other, want to add to that a little bit? Yeah.
Conflicting values and desires.
Yeah, absolutely. So it's, I mean, for me, it's sort of like, oh, I really want to eat. I had maple whoopie pies at the counter last night. I was like, God, I really want to eat one of those. And then I was like, okay, we're wearing the stretchy skirts. If we keep eating the maple whoopie pies, there may be the buying of new clothes. So which way am I going to go with this? You know, it's it can be tricky. So
whoopie pies, of course.
Whoopie pies. It was little, so the whoopie pie did win. It was like this thing, but it was so good. But that, I mean, that is sort of a basic function of the human condition, right? Like, I want to push snooze, and I don't want to get in trouble for showing up late to work. I would like a raise, but maybe I don't want to go through the craziness of a whole job interviewing, looking for a new thing process, and so you know, it's the back and forth. So, can we go to the ambivalent slide? So it comes from ambi, which means both, and valence is direction. So, you know, it can often be conflicting values. For me, it's often, I want to love and accept people the way they are, and I think the world is structurally unjust, and I want that to change. And often those two things pull me in completely different directions, and I don't know what to do. And I'm sort of like, trying to figure it out. So this is a normal part of being human, especially when we're trying to change behaviors, because most of our behaviors that aren't good for us are pleasurable in some way, or help us avoid pain, and so that makes them hard to change. So I think understanding ambivalence not as a problem, you know, not as you're an indecisive person, or why can't you manage your diabetes better, or why aren't you motivated, but that there are legitimate things pulling someone in two directions, and that part of working with them is helping them navigate that. I think it can be really helpful. So comments or questions about ambivalence? Okay, moving here. So defenses, we could spend like an entire forever on just on this, but I think it's a helpful frame to understand. So the idea is that all of us have protective behaviors that we mostly learned in childhood to deal with things that were hard to deal with. So things that were scary, things that were overwhelming, things that were out of our control. So that can be dealing with situations or just with feelings. And most of these defenses, you know, kind of made sense in their context, but that they outgrow their usefulness and become problematic into adulthood. And we all have them. So this skillful, unskillful, you can deconstruct the frame if you like, but the way it was sort of broken down is common unskillful defenses. So rationalizing, intellectualizing, I mean, we probably all have that, like, or maybe some of us are the brainiac friend who, when something happens, always has a mental way of engaging with it to sort of keep it at a distance or make sense of it. Denial and repression, I see this one a lot in working with people with HIV, especially folks who are newly diagnosed, that the shock of what it means to be diagnosed with HIV, the idea, you know, that people grow up even now thinking you get HIV and you die, and no matter how much kind of public education there is, that's usually the first thing that people think. So often folks go into months or years of, I'm not, or I can't deal with that, or I'm gonna, you know, get really drunk or high for a long period of time. That's not to have to deal with it. So I think it's a pretty normal protective response, but it can be really challenging. I mean, even with diabetes, you're working with someone who's like, you know, I'm not diabetic, I don't really have this, I'm fine. And it can be hard to know what to do, but I think recognizing it as a defensive, protective behavior can make it easier to have some empathy when folks are really stuck in this way. Acting out. Can someone explain acting out? If you have children, you should probably know what this looks like. Anyone?
I think it's just a way for them to deal with the stress.
Yeah.
Put it out there.
Yeah, so acting out is like, you know, I'm trying to think. So it's usually, you know, childish, childlike behaviors in a way that doesn't actually sort of fit with what's going on. So it's like if if someone cuts me off in traffic and I get really frustrated and I come home and then I start, you know, cleaning the kitchen in a raw way, and it's like, I'm not mad at the kitchen. I have a feeling of anger about something that happened before that I don't know how to deal with, and I'm sort of spewing it around. So it's a way of kind of trying to discharge or release stress, but often, we see that with clients, you know, the clients that blow up in the waiting room, or the clients that fire their doctor and come back 2 weeks later. Yeah.
I think it's kind of, when we get patients come in and they're angry about what's happening in their life, and they're venting. They're very voiceful and very emotional and very defiant and defensive, and just allowing them to get it out, and then all of a sudden you kind of get to the root of, okay, why are you really here?
Yeah. Yeah, a lot of times we see those acting out behaviors, and it can be really easy to get frustrated or to say, oh, we just can't work with that person, as opposed to sort of understanding there's a lot underlying, and the acting out is their best way of dealing with it.
And it's allowing them to act out and not responding to it, or not reacting to it. And
yeah.
just stay calm, and then when they're finished, then you can sit down and get to the point.
Thank you.
I always see acting out as incorporating the concept of pushing the boundaries of a social norm. Like
That's
a
nice.
little
Can you think of an
outside
example?
Like just, well, the road rage. Okay, road rage. It's not.
It's not socially acceptable
it's
to
not
crash
okay
into the
to
car in front of you.
You know, to give the finger to somebody. But that pushes a norm.
Yeah.
And that's acting out.
Absolutely. Absolutely. Or, I mean, I think about it in terms of social norms, like, you know, you get pulled into a party you don't want to go to. You drink a little too much, and then you're a little rude to the people at the party, and you're like, oh, that's acting out, right? Instead of saying, no, I don't want to go to this party, or I'm uncomfortable being here, I'm going to go home, we all do it, right? Thank you. That's a nice way of thinking about it. So the next one is compartmentalizing, and I did this training recently with a healthcare team in New York, and they were fans of compartmentalizing. They're like, we think it's good, it's helpful, we like it, and I'm like, okay, I'll entertain that as a possibility. So compartmentalizing is like putting things in boxes so that they don't mess up your life. So maybe you're gonna lose your apartment and you're stressed, you put that in a box and you come to work. And maybe your kid is sick and you have an important meeting and you put that in a box and you go to your meeting, and then your meeting goes badly and you're like, uh-oh, and then you put that in a box and you go home and take care of what you gotta do. I think a lot of us get good at it. It's like, okay, what's the line between multitasking and compartmentalizing? But I think the example I can think of is if there's stuff that needs to be dealt with, you know, you're dealing with an illness, you're dealing with a death, you're dealing with something that's painful and it gets put in a box and kind of put away, that compartmentalizing can kind of have negative effects on the whole rest of somebody's life. So it's a good kind of short-term survival strategy, but if you don't go back to the boxes, it will impact your health and your mental health over time. Yeah, go ahead.
But you actually said it, but the word that jumped to my mind was unresolved or unaddressed issues. So it's there, but there's like leaching into your person.
Absolutely. And a lot of times we're not even conscious. It's like, oh, I don't feel very motivated. What is that about? And it's like, oh, there's something that needs to be dealt with that's in a box, and you're not going to feel motivated until it gets addressed. But often it takes a while to figure that out. Dissociation, so you know, we're not going to do a whole segment on trauma, but often dissociation is a trauma survival behavior. So if you're a young person and something bad is happening that you can't escape, you kind of leave your body, go on the ceiling, go somewhere else, just kind of, you know, disappear. And that is a really helpful strategy for safety in those kind of traumatic moments, but it's really challenging to work with. I don't know if any of you have clients that dissociate that you know of, or people in your life, but it can be really hard because if there's a trigger that in any way reminds the person of something that feels dangerous, they often will leave, and it's hard to get them back. And often if they're dissociated, it's hard for them to be safe and to make good decisions for themselves when they're not fully here. Yeah. Reaction formation, this is also a very interesting one that makes some sense when you think about it. Does anybody know what this is? Have you heard this term before? So let's say, I actually don't have a boss, I'm my own boss. I don't know why I keep making these boss examples, but often these reaction formations happen in a situation where there's a power dynamic. So let's put it with a client. So let's say a client has a worker that they really, really don't like. They feel disrespected by, you know, the worker comes late to their appointments, like does obviously thinks that, you know, they're a waste of time, they're not gonna change, kind of given up on them. So burned out worker, client, and instead of being pissed off or making a complaint or you know, asking to be transferred, the client may be super extra duper nice to their worker that they hate and feel disrespected by. And so they may, you know, bring them gifts, they may tell everyone their worker's great, they may you know, praise them in front of other people at the workplace, and the idea is that the I hate you or the I feel disappointed and frustrated in you is so threatening that the person has to kind of substitute with its opposite. So you see like flavors of that when people are sort of being passive aggressive. That's maybe a little more conscious way that it plays out, but often if you have really negative feelings towards someone who's especially in a position of power, it's not safe to express that directly, and so it comes out in these strange sideways ways. So just an interesting thing to notice. This one is, I don't see it as often, but I think it also may not be as conscious. But I think what all these defenses have in common is, you know, I feel something uncomfortable, either I don't know what to do with it, it's socially unacceptable to express it, I'm trying to protect myself, and so it comes out in some other way that can potentially be harmful. And this is clients and us. So the frame for mature defenses, I think any of these can be done more or less skillfully, but there were three in this framework that I thought were that are interesting. So one is sublimation. Anybody know what sublimation means? So instead of coming home and trashing the kitchen after I have a fit of road rage, I go get on the treadmill. And the anger transmutes into something else. So if you know that you're really frustrated, maybe instead of coming home and eating a pint of ice cream, you're like, I'm gonna take that and go for a walk and look at the beautiful sunset. And so it takes the uncomfortable emotional energy and finds it another place to go that is more doable. So you see, like a lot of folks with anxiety will sublimate into exercise, and that's actually a recommended treatment. Is you take that and you give it a place to go. Compensation. So I think this is also a good one. So I think it has just the idea that we all have strengths and weaknesses, and so if compensation as a defense is sort of, instead of saying I'm just going to focus on my strengths, is I'm going to look at the areas where I'm not as strong and try to build them up so I feel more capable of dealing. So I'm trying to think of an example of this. If anyone can think of an example, throw it out. What would be a good example of compensation? Nothing is coming into my head right now. But just the idea that in situations that are uncomfortable, if we get better at the things we're not as good at, then we're more able to deal with what's in front of us. Like, so for me, being organized is challenging and being on time is challenging. And I'm much better with the go with the flow, create, let's see what happens. And when people are like, no, this needs to happen in an exact time, I have a really hard time. And so I've been trying, to compensate by doing more planning ahead and creating more structure and partnering with people who have some of the skills that I don't have to kind of create something that's more workable, if that makes sense. And the last one of these is assertion, which is basically like, I'm clear about asserting what I want and need and how I feel. So, if the feelings are intense, you kind of wait until they calm down a little bit and then you say, that wasn't okay, or I need a different job, or someone else needs to work with this client, or I need a vacation, or you can't talk to me for the next hour, or whatever the thing is that kind of sets some of those limits and boundaries. So why is this helpful to know? I think if you can think about people's behavior in terms of defenses, it helps us shift from a place of blaming to a place of empathy, because we all do this stuff in our own ways. And also, if you can help the person that you're working with figure out, whether it's a staff person that you supervise or a client that you're working with, understand some of what's going on for them, they may be able to manage it better or choose a defense that has maybe a bit less destructive consequences, if that makes sense. So in your folders, there's a full article with more detail about all of the defense mechanisms, so you can take a look at that at your leisure and take with you. Questions or comments about defenses before we carry on? Yeah. Mike, can you?
It's me again. I'll try to be quiet.
I can give an example just from a radically different context. I was a business manager and I had a business mentor, and every time I would see her, she would tell stories. So one of these stories about moving from a place of blaming to empathy is she had a customer come into the shop and just berate her. And so she let her this is just in real life, let the customer vent, and then she came around outside of the counter, put her hand on her arm and said, I don't know what's happened to you today, but I can't help you. And she says, I'm really sorry you're having such a bad day. And the woman burst into tears, and then they had a much more fruitful conversation. And this is just in everyday walks of life. And so it's that sense of not blaming or judging that person, but letting them be and then empathizing that brought a far more constructive dynamic in the least expected places.
Mhm.
So
That's
that
great.
carries over into everything. I think.
Thank you. And I think it's a really nice point to think about how do we practice that kind of empathy in the world. But I also want to say too, it doesn't mean people get a blank check to behave badly. You know, it's not like, okay, we're empathetic and so you can explode all over everyone and it's fine. It's just about how do we move from a place of reacting to a place of sort of a clear empathetic response that either de-escalates or creates some kind of safety in the situation. And that's, you know, practice over time. So moving on to projection. So this is a really interesting thing. So again, if we have feelings that are uncomfortable, rather than saying, I'm feeling thus and such, you toss it onto another person. So often a partner, an authority figure, someone that's on your care team. So if if you feel something that makes you feel ashamed or challenges your idea of who you are, I think, oh, I'm this peaceful, loving person, then I find myself really hating someone. I may be like, oh, I'm fine with that person, you hate them. And it's not necessarily a conscious thing that you pass it along, but there's a way that it's hard to own things that we feel that are uncomfortable. So, an example of projection, I think about, this is actually a client situation that, we have a client that's in our HIV adherence support program, and his boyfriend is so judgy and controlling and checking his text messages and is convinced that our client is cheating on him, and lo and behold, you find out it's actually the boyfriend who's been cheating. But instead of him saying, oh, owning his own feelings and behavior, he's putting it onto his partner because it's too uncomfortable to acknowledge what's going on. And I think that kind of thing is pretty common among humans. So I think the thing about projection is self-awareness is really helpful. And the goal is not about judging ourselves or other people, but making more space so that we can feel the stuff and we don't have to throw it onto somebody else. Comments, questions about projection? So this is not a technical term, but I think it's helpful. I think about baggage as being things that clients bring into their work with us and that we bring into our work with them. And I think doing HIV work, a lot of the people that do HIV work are HIV positive themselves, and many others of us have lost friends and family members, people that we loved deeply to HIV and AIDS. So ungrieved losses is a big thing in that work. So if you have losses in your own life, in your family, in your community that have not been grieved completely, they get carried along. Because grief is hard work, and we don't really live in a culture that supports taking the space and time that's needed for a real grief process to happen. I think it's insane. In the DSM, which is the mental health diagnosis book, the sort of international, they say symptoms of grief are supposed to last 3 months, and then after that it becomes a potentially diagnosable mental disorder, which I think is insane and wrong. So there's not a lot of support around grief, and especially if it's something like, I worked with a client for 4 years and she died. We know maybe better how to grieve, a grandparent or cousin or neighbor, but when it's a client and you have this relationship that's both intimate and not, can be really confusing. So when we don't grieve those losses, they drive our behavior in interesting ways. So I've seen staff who've had clients die then get really hypervigilant about clients dealing with something similar, and will start crossing boundaries because they're afraid, oh, my other elderly patient with COPD died, and I'm not going to let that happen to anyone else. Sometimes when you don't grieve the losses, you just get burned out and you're like, they're just going to die anyway, so what do I care? It's hard to motivate to do life stuff, work stuff. So it impacts in a lot of different ways. The second piece of baggage, and this number 2, I learned this in grad school, and it's brilliant and I hate it. So it's the concept is repetition compulsion, and the idea is that we unconsciously seek people in situations that are similar to what we grew up with, including the really problematic parts of what we grew up with, because we're trying to resolve it in some kind of way. So what feels like love, what feels like home is shaped by those early experiences. And even when you make the decision, you know, let's say you grew up with an alcoholic parent, there's some kind of strange gravitation towards people who show some of those same behaviors, or you may find that you start showing them themselves. So often, you know, if you grew up with a really critical parent, you may choose a really critical partner, and you hope, oh, if I can just get the critical partner to praise me and see me and not criticize me, then I'm okay, and it somehow resolves the stuff from the past. And unfortunately, it doesn't work. But it's an opportunity to sort of look at what stuff we carry that's not healed and try to deal with it. I think the reason I get so irked by this is it's like, it just seems like if you deal with really hard shit growing up and then you have to deal with it again, it's like, okay, so you grew up with domestic violence and then you recreate domestic violence, and it's like, wasn't it bad enough that you had to deal with it the first time? But there's something psychologically kind of trying to work itself out. But I think understanding this both helped me have more empathy for myself and some of my repetitions, but also, you know, I have my friends who choose the same kind of like abusive partners over and over again, and it's like, what do I do with this? What is this about? Why does this keep happening? And I see that with clients as well, you know, that repeatedly put themselves in unsafe situations, and part of me wants to rescue them and part of me wants to blame them, but understanding that there's something unconscious and old that's trying to get healed has helped me not get so caught up in it, and have maybe some more peacefulness about just walking with people through pretty ugly situations. Comments or questions about repetition compulsion? There's lots to read if you want to read and learn more about it, and it may also make you angry. So I want to talk about transference and countertransference, and I'm going to let someone else do a little piece of the work here. So let's see if she'll talk, and if not, I'll pull this up on YouTube. No, go back, go back. This is a very tiny computer. Yeah. So let me know how the sound is here. So this little talk, there's a lot of stuff, and what I like about it is it's brief and she's funny. But she was giving, she's a sort of a trauma expert that does training nationally, and this was from a piece of a training for lawyers, EMTs, and first responders around understanding transference and countertransference.
Now this is very important. We're going to get into shrink speak for a minute, but it's important that you know that, because this is a phenomenon that actually takes place in every helping relationship. Has anyone here ever heard of the term transference? Okay, transference is a phenomenon that we notice and we analyze and process in the psychotherapeutic relationship, whereas the authority figure, we become a symbol for one or both of the client's parents or other authority symbols in their life. And you know, usually a client who is in psychological trouble or in legal trouble many times didn't really have an optimum relationship historically with one or both of their parents. So when that happens, they are unconsciously putting on you any negative feeling, any upsetting feeling they might have about that parent. And so they may become irritated at you, short with you, critical of you, question your professional judgment, or they could go the other way, where they worship you, which is not any better. You know, when somebody tells me, oh, Ellie, you are the most wonderful one, I'm like, yikes, I don't want to be that. So in your helping relationship, you need to be very aware of the phenomenon of transference, because that client sees you not only as their lawyer, but whatever you symbolize to them in the way of a parental symbol. Well, conversely, the same thing happens to us. You may get a client from time to time that will remind you of one or both of your parents, the good things and the bad things. No one had a perfect upbringing. We all had good stuff and or bad stuff, some in different ratios to the other. But there may be a client from time to time that is going to help stimulate that hippocampus in your brain and is going to trigger for you upsetting memories. So now the client is telling you an upsetting story. The story is reminding you of some aspect of your own history, your own background. Now your trauma response is exponentially intensified because now you're having secondhand shock perhaps from the story itself, and you're having some old trauma or shock from a memory it triggers in you. Does anyone have a sense of a client or a person that just pushes your buttons?
Okay, come on. Tell us the kind of client that most upsets you. What kind of people trigger you when you're around them? Yes.
People who won't tell you the truth.
Liars. Okay. What else? What other kind of people may come to you? Oh, you're far away. Okay.
Negative people.
People who are always negative.
People who see the downside of everything. We have one back there.
People that are hypercritical.
People that are very critical or judgmental, that really pushes your buttons. This kind of awareness is so important because guess what? If someone is hypercritical, someone is judgmental, if someone is very negative, that's about them. If we get upset about it, that's about us. And I hate it when it's about me. I really like it best when it's not about me. But it's important to know that. And the reason why you may have a reaction is because of your own history. So one of the things we want you to start to become very close to and very intimate with is your own development, your own history, your own evolution, the players in your life, your relationships with authority figures in your life, what was good about it, what was trying about it. Because when you are listening to upsetting stories, and it happens to be with a type of person or a story that has something to do with your own history that may be painful, you are really going to get a double whammy of secondhand shock, and you are going to get an intensified chemical reaction in your brain. If you remember that brain picture, we've got that hippocampus there, and we've got the amygdala. The amygdala gets stimulated, the relay station starts, memories get triggered, and now you're feeling on an exponential level. Not only the empathy for the client that you have to control, but now you have to control your own memories from coming up to the surface. Reason why we tell you this? These are body memories. It doesn't bother me so much that you may remember it cognitively. It's all the other chemical reactions that memory trigger in your body that put you at risk.
All right, so transference is the stuff that comes up for clients in working with us. And there are some models of therapy and counseling that really see that transference as something you work on in the counseling relationship. And for those of us that are doing more of care coordination, case management, accompaniment type of work, that transference that comes up can be hard to deal with because it feels like the client is putting something on you that has nothing to do with you, or is having a really strong reaction to something you do that doesn't really make sense in light of what's happening. So, figuring out how to work with that, I think, is an important piece of this whole puzzle. I want to spend a little bit more time talking about countertransference, just because that's something that we can do something about. So countertransference is our stuff that comes up in response to clients, colleagues, supervisors, in workplace. So some examples. So thinking about a SASH coordinator working with an elderly patient who reminds her of her deceased grandmother, goes by and visits the client every day, even though she's supposed to go there once a week. And it's like, is that about the client or is that about the worker? And if it's about the worker, how do you work with that? Another example, social worker who once lived in a domestic violence shelter with her kids starts to freak out when her clients are at risk of losing their housing, or she sees any possible clues of domestic violence in the home, and then gets really overprotective of clients. And these are all real examples. Patient navigator in long-term recovery from heroin addiction who thinks his clients have to hit bottom before they get better, so doesn't make much of an effort to work with them if they're actively using. And last one, an outreach worker who identifies as queer that avoids meeting with a new client who appears very religious and reports attending a fundamentalist church. So when you look at these examples, you can see that the responses that the staff person is having make sense. But what's the risk if we let the kind of countertransference run us and sort of shape how we make decisions about working with clients?
I think there's a lot. I mean, the first would just be burnout. And then also, I think that we would not be seeing people on an unbiased way. I mean, our caseload would start to really reflect the people that we were comfortable with instead of everyone that we were supposed to be working with.
Yes. Well, and I think, I mean, how common is burnout, right? And also how common is people spending more time with the clients that they're comfortable with and less time with the ones that they're not. I mean, there are two things that happen in the work if we're not paying attention. Thank you. So if you're trying to figure out for yourself, if you're kind of like, okay, I'm having this reaction to this client, what's going on? There's a sort of little checklist, and I didn't make this up. The link is here from a psychologist that does a lot of work with homeless clients, runs a homeless psych clinic. So the kind of checklist to run through is, so let's say a client does something and I get really angry. Is the feeling characteristic? Meaning, am I generally prone to anger? Is that kind of the place I go? And if the answer is yes, it's probably not about the client. It's like my general ways of coping and not something to spend a lot of time and energy on. Second question, is the feeling triggered by something unrelated to the patient? So if I get really angry and I realize I haven't eaten all day, or I'm getting a no caffeine headache, or I just got some really bad news about my own health and I'm angry, the client may have triggered it, but it's probably not about the client. It's about what's going on separate from that. So number three, is the feeling obviously related to the client? So if they come in and say, come to the clinic and curse me out, throw some chairs and then leave, and my response is to get angry, that makes a lot of sense, right? That's like a fairly logical, common sense kind of reaction. And so it's probably not countertransference, it's just a response. So the stuff that really is worth spending time on is things that, if you don't go through the first three questions to the fourth, is this feeling uncharacteristic of the worker? Meaning, I don't feel this way all the time, it's not so common. It's a reaction to a particular patient, but I'm not totally sure what I'm reacting to. That's your little flag that probably there's some countertransference going on. And so if you have clinical supervision or a colleague that you trust, those are the situations that really are worth spending some more time exploring and reflecting. It will kind of lead to going deeper to what's under the surface. So comments or questions about sort of understanding countertransference so far? So I think it's important just to know our own history, our own development, who are the players, what's your relationship to authority? Some of us were really raised to be, the good kids and do everything right and make the powerful people happy, and some of us are more of the skateboard, burn it down kind of adolescent stance. And so those things will play out in how we show up to work, how we show up to clients, how we show up to our teams. And I think to use the language from Dr. Ellie, she talks about the double whammy of secondhand shock. So not only, you're hearing about stuff from clients and you have that human empathetic kind of chemical response that happens, but also if you've had any similar experience yourself, all of that kind of chemical flooding can happen, and those two put together can be pretty intense. So if you're a supervisor and you're working with people, let's say you have formerly homeless people who are now staff, or people living with chronic diseases who are working with people with chronic diseases, this kind of compounding of that emotional intensity and that difficulty is just something to be on the watch for and to try to help people learn how to work with. So I think the big piece is none of this is wrong or bad. You know, so if I can't deal and I project something onto my coworker, it's only a problem if I can't recognize it and work with it. So, you know, all of the defenses, as well as transference and countertransference, are normal parts of being human. It's not a sign of mental health problem, but when we can work with these things more skillfully, it protects us in terms of keeping us behaving consciously and professionally, and also as a protection for our clients. So I want to give you all a little bit of time to think about, so if you think about a client or a patient that you have strong feelings about. So it could be someone that you love, that you know, look forward to seeing, that you would take home with you if you could, or someone who you're like, oh God, here they come, I gotta get myself mentally prepared. So strong positive or negative reaction. And if you can just flip over your self-assessment and do a little journaling on the back. So what is it about the behavior? Like, what are the specific behaviors that push your buttons? And just riff a little bit on what is that about? So, you know, maybe it reminds you of a parent, maybe, you know, it goes against some strong thing that you hold as important, but just do a little bit of reflecting on it. And when you're done with your reflecting, I want you to join up with 2 people at your table and just share a little bit about what you learned. And together, if you can come up with a strategy or 2 about, you know, when you come face to face with this behavior, what could you do that you haven't done that would help be more of a response and less of a reaction? So a little journaling and then some sharing with a couple people at your table. Questions? You clear what happens now? Okay, so I will keep time for us. Just wondering if there are any folks who would be willing to share an example of the behavior that pushes your buttons and maybe a strategy to approach it based on your conversation. Anybody want to share with the whole group anything you discovered? Hopefully the conversations were fruitful. It looked like people were engaged with each other, which is always good. So I just want to spend a minute and sort of elaborate on what we were speaking about before. So I think one of the reasons I feel like this is so urgent is that if we don't deal with the pieces of our own stuff that comes up, the consequences can be quite unfortunate. So we talked a little bit already about just not spending time equally and equitably across the caseload if we allow ourselves to avoid the clients that push our buttons and be drawn to the ones that inspire our affection and compassion. I think not dealing with our stuff is one of the major things that feeds boundary crossing, and that, you know, can get quite problematic. So rescuing, overwork, bringing work home, confusion about what's our role, what we can do, what we can't do. Increased emotional distress. So if we're trying to rescue a client the way we were trying to rescue a family member or a parent, it can be really intense to manage that, and it's not actually about the client, it's about us. So dealing with our stuff can make it more workable. Risk of lower quality care to some patients, for sure. Burnout, ethical violations. I had a colleague who was really good at what he did. We worked at a homeless youth program in Manhattan together, and I loved working with him, and the youth loved him. And there was a client that he just totally connected with, and who was homeless, and he just let the kids start sleeping on his couch. And you're like, I totally understand why you would feel tempted to do that, but it was really about him and his own experiences of having been homeless that he swooped in to rescue this guy and stepped way out of his role. He ended up getting fired for boundary crossing. So I say that just to say there are plenty of us who are smart, sane, competent people that when it pulls at this old stuff, do things that are not professional and that become problematic. So in terms of best practices, there's a lot of great ways to work with our human being stuff. So clinical supervision, I don't know if all of you have access to it. If you do, please use it either individually or on a group. And if you're a program manager, it is not that cumbersome or expensive to bring in a clinician to do some work with your teams. And I think it makes a huge difference to preventing burnout and really helping people stay in a healthy place with their work. I definitely refer people on my teams to outside therapy. And for some people that's more okay than others, and for some people their insurance makes that more possible than others, but I think it's a really helpful resource if you find that your personal stuff is playing a big piece in how your work is happening. Peer support is a really helpful thing, so that's part of what we're trying to do here, but also really encouraging you to use your colleagues as a support in that way. Taking time away from work, so you actually, eat your lunch, take your vacation, don't work more hours than you're paid to work. And some workplaces are really good about this, and other places the culture of the agency really gets in the way of that kind of healthy boundaries. And revisiting your boundaries regularly. So I do boundaries training, and one of the activities we do is pros and cons of policies. So for example, our community health worker program has a no clients in the car policy. And when there's not good transportation, there are a lot of drawbacks to that policy. But from a legal liability standpoint, there are a lot of pros. So we revisit those periodically and sort of say, okay, if here's the boundary, what's working well about setting it there and what is working not so well. And it may mean that after we do that reflection, we shift a policy or we shift our habit around where we set boundaries. But really the goal is just self-awareness without judgment so that we're able to respond skillfully to the things that come up in our work. So I'm going to give us a break here. We're running just a little bit behind time, but not in a tragic way. So it is 11:11. So if you can be back and ready to go 11:25 or so, that would be fabulous.